Good morning, everyone, and thank you for your interest in participating in the Bidders Conference for the Universal Nurse Home Visiting and Community Health Worker Request for Proposal. My name's Debbie Puerio. I am the Durational Project Manager for the Universal Nurse Home Visiting Program at the Office of Early Child, and I'll serve as the moderator for this conference. The agenda for today will include the following: welcome and introductions, an RFP overview, an overview of the Universal Nurse Home Visitation and Community Health Worker programs, key dates and next steps, and the closing. At this point, it's my honor to introduce Dr. Deidre Gifford, one of the 5 commissioners instrumental in the development and funding of the Universal Nurse Home Visitation Community Health Worker Pilot Program.
Thank you, Debbie, and good morning, everyone. I'm Deidre Gifford from the Department of Social Services, and thanks for that introduction. I'm really, as Debbie alluded to, representing a number of commissioners this morning, as well as the Office of Policy and Management and the Governor, in welcoming you and thanking you for your interest in this really, really important program. We have been for a very long time, since the passage of the American Rescue Plan Act in Connecticut, thinking about ways to use those funds that were provided to us in ways that were transformational, and that was really our directive from Governor Lamont. And one of the things that we've been working on is the result of which is what we're talking about this morning. We know that the pandemic has had disproportionate impacts on communities of color and low-income communities, not only in Connecticut, but all across the country. We also know that it has been particularly challenging for women and young families of all income strata and all races and ethnicities. There's good evidence that the pandemic has had really significant mental and behavioral health impacts on women and families in particular. And so we really are privileged that we had the opportunity through some of this American Rescue Plan Act funding and CDC funding to work on developing this program. And we know that home visiting programs have very good data behind them in terms of the potential, not only near term, but long-term impacts on the health and well-being of the child and the family. And so we really are focusing on the root causes of some of the long-term challenges that we're seeing in Connecticut and across the country. Youth and teen mental health and substance use challenges, food insecurity, maternal morbidity and mortality. Many of these things have their roots in early childhood. And so we are taking this step to begin the process of what we hope will be a statewide and universal home visiting program for the state of Connecticut. An innovation for us in Connecticut is pairing the home visiting with a community health worker program, because we know that many of these families will have resource needs and other needs identified during the course of the nurse home visiting program, which is limited in time and scope, that they will have referral needs. And so we want to make sure that to the extent we can, we are pairing that family with a community health worker who's a trusted member of the community and who has specialized training in the challenges facing, in particular, women and families, and that person could stay with the family, providing support and resources for up to a year after the birth. So this is an add-on to universal home visiting programs around the country, and we hope to demonstrate that that's a really important and significant additional component of the program. The other thing, last thing I'll mention, and it's the U in this, the title of our program, but we really wanted to focus on the universal aspect of universal home visiting. As many of you know, we have home visiting programs already in Connecticut that are focused on individuals and families with particular risk factors, and usually those at the very highest end of need. But we felt it was very, very important to destigmatize any program and be able to say to the women that are giving birth, every family is offered the opportunity for this nurse home visiting program. It's not because you come from a particular community. It's not because you are of a particular race or ethnicity, but every family giving birth in this hospital is going to be offered the opportunity to have a home visitor. And we hope that people of all races and ethnicities and all income strata will take advantage. And we know it'll take time for this type of a program to become ingrained in the culture of our birthing hospitals and our perinatal care system, but we very much hope that it gains acceptance quickly, and we'll be counting on whoever is the eventually successful bidder to help us with that community engagement process. So on behalf of Commissioner Bai, who's really been our champion on this process, but who couldn't be with us today, Commissioner Bai, Commissioner Durantes from DCF, myself, Commissioner Navarrete from DEMIS, Commissioner Sheff from DDS, Vicki Veltri from the Office of Health Strategy, and I've probably forgotten one along the way. All of us are deeply committed to this program, and we thank you for your interest. And with that, I'll turn it back to you, Debbie.
Thank you, Commissioner Gifford. I'm now going to ask the speakers for today's conference to introduce themselves. Ashley?
Hi, good morning, everyone. My name is Ashley McAuliffe. I'm the Family Support Division Director with the Office of Early Childhood, overseeing the home visiting program and the Birth to 3 program.
And Kathy?
Good morning, everyone. I'm Kathy Lenahan. I'm the Director of Grants and Contracting Support Unit here at OEC in our Operations Division. And we provide oversight and support for both RFPs and the contracts that will be executed as a result of this RFP. And welcome. We're glad you're joining us this morning.
Thank you, Kathy. A few logistical issues to review prior to commencing with the RFP overview. As a disclaimer, this presentation includes brief descriptions of the RFP specifications and requirements, but does not fully elaborate on all required elements. As a result, this presentation does not supersede what is stated in the RFP or its appendices. Proposers are responsible for ensuring that their proposal is complete and accurate according to the information and requirements contained in the full RFP. Additionally, OEC will post slides on our website and on the state contracting portal after this conference. In regards to questions are to be submitted to oecrfpuvh@ct.gov by Thursdays at 5 p.m. Questions that have been previously submitted prior to June 29th will be answered in writing and posted to the OEC website on Friday, July 1st, 2022. Questions submitted today in the chat box of the bidders conference will be answered in writing and posted to our web page on July 8th, 2022 by 5 p.m. And finally, questions submitted from July 7th through the 28th will be answered in writing and posted on July 15th, 29th by 5 p.m. Please remember to type all questions for today's conference in the chat box. They will be responded to, as I said, on July 8th. This conference will also be recorded, and OEC will post on our website, the state contracting portal, after the conference, the entire bidders conference and the questions, as we stated, per dates that we will respond. OEC will post the conference slides by July 1st. Before we dive into the details of the RFP, we wanted to provide answers to a series of central questions about the Universal Home Visiting and Community Health Worker programs. Through this RFP, the OEC and its partners are seeing applicants to administer either one or both of two complementary but independent programs that aim to improve the continuum of care for families in the greater Bridgeport region following birth. We will provide more information in the following slides, but at the highest level, the two programs are: one, an evidence-based universal nurse home visitation model called Family Connects, which will offer a home visit to all families in the weeks following birth. And two, a community health worker program that will offer longer-term services to families who exhibit additional needs. Universal home services will be offered to all families who give birth at either St. Vincent's Medical Center or Bridgeport Hospital and live in one of the cities listed on the slide to follow. Those cities include Bridgeport, Easton, Fairfield, Milford, Monroe, Shelton, Stratford, and Trumbull. Community health worker services will be offered to the subset of those families who would benefit from further support. There will be $4.5 million in total funding available across both programs for a 24-month contract. The application is open to both public and private organizations who can demonstrate the ability to work on the ground throughout the greater Bridgeport region with a focus on collaboration with community and medical partners. A single organization may submit a proposal for both the universal and community health worker categories. Proposers may also submit a proposal for a single category. However, these proposals should be paired with a proposal of the other category and demonstrate coordination and integration. They will be scored separately, then aggregated as one single application for scoring purposes. Now that we've provided a basic overview of the what, we want to return to the why. Families across Connecticut are impacted by various challenges, such as the ongoing and lasting impacts of COVID-19 and widespread racial health disparities. Additionally, although Connecticut has an existing home visiting network, there's a gap in prevention-oriented services that bring families into the continuum of care and create the structures to elevate family strengths and address issues, such as adverse childhood experiences before they develop. The RFP aims to, 1, reduce the impact of COVID-19. Early touch points with families, such as those provided by the Universal Home Visiting Program, can provide support during critical periods and reduce poor health outcomes, such as rates of maternal depression, which have risen significantly during COVID-19. 2, reduce disparities by race across health outcomes. This RFP will allow all families in the greater Bridgeport region to access a nurse who will screen for and address behavioral and medical concerns before they materialize. Because services are offered to all families, this will help address issues of stigma that currently impact the uptake of targeted home visiting and other services. The RFP will also build a robust community health worker workforce who will represent the racial and ethnic backgrounds of families served, thereby expanding access to care within and from non-white communities. And 3, This RFP will address a service gap. The early care system in the greater Bridgeport region and Connecticut at large reaches a fraction of families with needs. These services will ensure that families with needs are brought into the continuum of care and referred to necessary supports as community health worker services. The OEC and the partnering agencies supporting this RFP are excited to collaborate with service providers to achieve these objectives. As for the procurement schedule, RFP responses are due August 3rd with an intended contract date of October 1st. Future key dates are as follows. Mandatory letter of intent is due July 13th by 5 p.m. Proposal is due August 3rd by 5 p.m. The anticipated selection of the contractor or contractors is scheduled for August 17th, 2022. Contract negotiations will begin August 17th through September 30th with an anticipated start date of the contract being October 1st, 2022. The RFP outline includes the following sections: general information, the purpose of the RFP and scope of services, the proposal submission overview, required proposal submission requirements, mandatory provisions, and the appendices, which include abbreviations, acronyms, and definitions, the statement of assurances, letter of intent form, and the proposal checklist. Additional detail can be found in the RFP on the pages listed to the right. The proposal outline components include a cover sheet, the table of contents, executive summary, which will include a 2-page high-level summary of the proposal and the budget. The main proposal will include the following components: the organizational profile, organizational experience, respondent references, and whether or not they're part of a small minority or women's business enterprise. Please adhere to the pagination requirements on the right that include the proposer's name must be displayed in the header of each page. All pages, including the required appendices, attachments, and budget forms, must be numbered in the footer. The following attachments are required: the declaration of confidential information, the conflict of interest disclosure statement, and finally, the style requirements for the proposal are listed here. They can also be referenced in the RFP. The total number of pages for the RFP cannot exceed 35 pages if applying for a single category, or 45 pages for an application to both the categories, which would include the Universal Nurse Home Visitation Program as well as Community Health Worker Proposal. And finally, the last section would be the cost proposal. As Dr. Gifford referenced in her introduction, mental health issues, especially maternal depression and anxiety, have more than doubled during COVID-19, causing an increase in perinatal morbidity and mortality that's resulted in over $14 billion a year nationally. Family Connects is the only evidence-based universal nurse home visitation model that has proven effective in improving maternal health and child outcomes, including a 50% reduction in emergency room visits and hospital overnight stays, 44% reduction in child protective service investigations, a 30% reduction in mothers experiencing postpartum depression or anxiety, and a 15% increase in community connections. And Family Connects has been found to generate over $3 for every dollar spent in program costs. To summarize the intent of the pilot, OEC identified the need for prevention-oriented home visiting nursing services to provide early identification and intervention to families by addressing physical and mental health concerns in a non-threatening approach to wellness. Pilot program will offer the universal nurse home visiting through the evidence-based Family Connects model to families who give birth at either Bridgeport Hospital or St. Vincent's Medical Center and who reside in the catchment area, which includes 1 to 3 postpartum visits where families will be assessed for needs. And finally, families with additional needs will be offered support from community health workers with a focus on serving Medicaid eligible and non-white families. We'll now proceed with providing you with an overview of the Family Connects model. In an effort to provide you with this overview, Family Connects has provided us with its pre-recorded 10-minute video.
Hello, and thank you for your interest in the Family Connects model. This presentation will provide an overview of the Family Connects model, including the core components of the model, model history and research, model training and certification, and program operations. Family Connects model, as it is known today, was founded by Dr. Kenneth Dodge at Duke University with the goal to reduce child maltreatment at the population level. The model was created with the intention of replication and is currently being implemented in communities across the country. The Family Connects model is evidence-based and underwent rigorous monitoring and evaluation in multiple randomized controlled trials, or RCTs. There are many notable lessons learned from the RCTs, including that the birth of a child often brings needed education and support. 94% of all families needed some kind of support, which indicates that this is a very vulnerable time for many families. Results demonstrated a decrease in emergency medical care, which translated to return on investment for money spent on the program. For every $1 spent, a little over $3 were saved. This holds true for 24 months after birth. After 60 months, there was also a community reduction in Child Protective Service investigations. Additionally, caregivers participating in the program were less likely to report depression and anxiety and were better connected to community resources. What exactly is the Family Connects model? The Family Connects model is an evidence-based approach to supporting newborns and their families. The program is available to all families in a given community, regardless of income or background. This approach reduces stigma and focuses on infants, families, and communities to address unmet needs and to identify critical gaps in the early childhood system to create population-level impact. The program is voluntary and is no cost to recipients. The goal is for Family Connects to become part of a community system of care for children and families. Visits are scheduled for around 3 weeks after a baby's birth. The visit takes place in the family's home and is made by a highly trained registered nurse. Nurses are trusted professionals and also necessary for the medical component of the home visit, such as taking caregiver and infant vitals. Nurses follow a standardized protocol, providing 1 to 3 home visits. During these visits, they also assess for needs like healthcare arrangements, caring for the infant, safe home, and parental support. If a need is found in one of these areas, parents are connected to a community resource for support. Our approach is not intended to replace intensive, targeted home visiting. As a matter of fact, they are critical to providing the long-term supports families need. Instead, we seek to connect families to those programs and help build a broader, more aligned system of care for families. The 3 core components of the model are community alignment, the nurse home visit, and data and monitoring. Each component is important and all components must work together in unison to achieve the common objectives. Family Connects ensures that community stakeholders are brought together for a common objective, supporting new families from the very start. The basic elements of the Family Connects model are outlined here. The visit is available to all families with newborns residing within a defined geographic region, which could be a region, county, city, or birthing hospital. The home visit is offered and scheduled prior to discharge at the birthing hospital. Ideally, the visit is scheduled face-to-face in the hospital post-delivery by a nurse or a program support specialist who can answer any questions a family may have. The home visit is approximately 2 hours long and includes nurse assessment, guidance, and education. The visit takes place between 3 and 12 weeks postpartum and ideally occurs at 3 weeks, But if special needs exist, such as a child in the NICU, the visit can be completed at a later time. A nurse may make up to 2 additional home visits and/or telephone calls as needed for further assessment and facilitating linkages to community services. A program support specialist makes contact with families 4 weeks post-visit to confirm families' successful linkages with community resources, ensure if the standard postpartum visit and infant pediatric visits were completed, and receive customer satisfaction and program feedback. Nurses receive 6 to 8 new cases per work week. A nurse is required to be a registered nurse, but is not required to have a BSN. The integrated home visit follows a detailed protocol called the Family Support Matrix to assess 12 factors predictive of child and family well-being. Scripts are provided to be used as a roadmap for guiding the visit, but the visit is meant to be an open-ended interaction. At each visit, nurses will provide physical assessments for the postpartum caregiver and the newborn, respond to immediate parent questions and concerns, offer supportive and anticipatory guidance, and connect the family with community resources as needed and desired by the family. Each factor is rated as the family having no identified risk factors, needs addressed during the visit, needs for connections to community resources, and urgent situations requiring immediate intervention. The results are used together with the family to plan for facilitated referrals to community services, including but not limited to targeted longer-term home visiting programs. Community alignment is the process of working with community agencies, systems, and individuals to impact systems level change. Our community alignment philosophy is that if you are trying to impact community system level change, it's imperative that you remember and promote the message that you are working with the community and not on the community. The community level outcomes are dependent on the program's ability to make appropriate and timely connections to effective community resources. These timely connections are facilitated by feedback loops that are created through collaborations and inform daily operations. The community alignment domains depicted here each provide a piece of the puzzle and together inform the broader whole. These include the Community Advisory Board, the Agency Finder directory that nurses use to connect families to resources in their community, clinical case conference, engagement with providers and community agencies, continuous data review of referrals and service trends, and the post-visit connection when program staff assess family satisfaction and effectiveness in connecting to resources. Family Connects values each family and aims to provide culturally responsive and respectful care to each family. Family Connects programs are serving diverse communities and populations across the country. Cultural responsiveness is defined as a core competency for all Family Connects program staff. Staff are expected to understand the unique values, cultures, and needs of the communities that they serve and to tailor their care for each family. Each new community teaches us how to listen, how to adapt, and that failure to do so will result in the failure of this endeavor. We are committed to learning about the strengths and needs of each community, to reflecting that community in the hiring of nurses, and to provide compassionate care to every family that we meet. Data and monitoring is a core component of the Family Connects model. These key performance indicators help us make data-driven decisions for clients and the community. They demonstrate our success in building relationships in the community, inform training needs, and illustrate how the community alignment process is unfolding. Program implementation indicators include the scheduling rate, visit completion rate, and participant demographics. Community capacity indicators examine the referral documentation and client self-report of their service connection success. Program integrity is measured by the home visit protocol adherence and inter-rater reliability among nurses. Community need includes the clinical assessment and risk stratification by each family support matrix domain. The Family Connects International Implementation Team supports community partners in achieving and maintaining program certification through a combination of collaborative cohort style and one-on-one technical assistance opportunities. Each community partner moves through the phases of development, planning, installation, implementation, and certification maintenance, completing the required deliverables for each stage. Community partners in the planning phase and those who are actively serving families attend regular cohort meetings, which accelerates learning and provides opportunities for partners to learn from one another. Each community partner also receives one-on-one technical assistance from Family Connects International staff for additional customized support. The goal of this process is to achieve model fidelity and implement best practices for each community. Each staff member of a local Family Connects program has an essential role to play in making the implementation of the model a success. Investing in adequate staffing supports the overall success of the program. The program director oversees the program and ensures model fidelity. The community alignment specialist is responsible for managing the community alignment process and is often the public-facing representative of the program. The nurse supervisor leads case conference and directly manages the registered nurses. The registered nurses provide home visits to families and facilitate resource linkages. The program support specialist may complete the post-visit connection calls, sign families up for home visits, schedule home visits, and provide general program support. The data and evaluation manager provides data reports to program staff as well as to Family Connects International. All staff work together to identify trends in the community and educate the community about systems-wide change. Universal home visiting is a paradigm shift that creates population-level impact. One nurse shared this story about a family she visited. Health disparities in our community are prevalent. The most critical visit I've made was to a mom who delivered twins. Mom reported that she was seen in the ER after passing a huge clot. She showed me a picture, and what I saw was very serious. During our visit, Mom was still experiencing bleeding and was rating her pain level high. But this is a time when her pain levels should have been minimal. Mom stated that she was told that the clot was part of normal shedding. When she reached out to her provider, she was repeatedly told that what was happening was normal after having twins. She was very reluctant to be persistent about the symptoms that she was experiencing. I explained that African American moms have the highest mortality rate in the United States and explained if she feels like something is not right, then she must advocate for herself so that she can be around for her children that need her. I was able to empower her with the knowledge and support to advocate for herself with her doctor. Covered well. Thank you for your time. Included in this slide are links to videos about Family Connects. Please contact us with questions. Thank you.
In Connecticut, there was a need to establish a continuum of care for mothers, infants, and families of newborn children in the greater Bridgeport area to address significant unidentified and unmet social, mental, emotional, and physical health care needs in the pre- and postnatal periods. The intent of this pilot is to strengthen the public health infrastructure and shift services to support equity throughout the state with the following outcomes in mind. Increasing connections of newborn families to community resources, reducing emergency room visits for mothers and newborns, improving positive parenting behaviors, reduction in the maternal depression and parental anxiety, improving the quality and safety of the home environment, and prevention and reduction of adverse childhood experiences. Therefore, in summary, the goal of the collaboration and integration of the Universal Nurse Home Visitation and Community Health Worker programs is to improve healthy births for babies and mothers, improve child development and parenting practices to strengthen families and reduce child maltreatment, reduce readmittance rates to hospitals for health and mental health issues and complications, and for the early identification and intervention in health and mental health issues of newborns, as well as maternal issues. The pilot catchment area is the greater Bridgeport region, which includes Bridgeport Hospital and St. Vincent's Medical Center, as well as its surrounding communities. The target population includes any family who's given birth at either St. Vincent's Medical Center or Bridgeport Hospital and who resides in the catchment area previously defined. All these families will be offered universal nursing, home visitation, and community health worker services. Greater Bridgeport area and the region includes the targeted communities of Bridgeport, Easton, Fairfield, Milford, Monroe, Shelton, Stratford, and Trumbull. And in regards to eligibility, any family residing in the targeted communities who's given birth at either hospital is eligible for the program regardless of insurance coverage. To summarize the integrated program, all newborn families residing in the catchment area, regardless of family income, are eligible. There will be a prenatal engagement and 1 to 3 postpartum visits from a registered nurse and or community health worker. And home visits will include physical assessments and connections to community resources. Again, to restate, the Greater Bridgeport area is the catchment area for this pilot. It includes Bridgeport, Easton, Fairfield, Milford, Monroe, Shelton, Stratford, and Trumbull. Utilizing ARPA and CDC funding, the start date is anticipated to begin October 2022 through September 2024. And again, to summarize, the intent is to address health inequities and promote healthy starts, provide early identification and intervention to avoid costly medical and mental health issues and reduce emergent care, and to connect families to community resources. In years 3 to 4, ARPA funds for the program there's a potential for Medicaid, philanthropy, and additional state agency funding to cover shares later in years beyond year 3 and 4. It's my pleasure to introduce Ashley McAuliffe, Director of the Family Support Division, Director, to provide an overview of the Community Health Worker Program.
Thank you, Debbie. Good morning, everyone. It's my pleasure to run through the next few slides with everyone on community health workers and the model and how it relates to the universal home visiting that we have just spent the past 40 minutes talking about. So next slide, please. All right. This slide demonstrates how these two independent but complementary programs can provide a coordinated and robust continuum of care. The OEC and its partners expect that the primary mechanism for coordination between these services will be that families who have additional needs identified through their nurse home visit will be referred to community health workers who can provide more lasting support. Community health workers can best address health disparities and social determinants of health and have an in-depth understanding of experience, language, and culture of the community. We encourage applicants to think creatively about additional opportunities for the Community Health Worker Program to complement the Universal Home Visiting Program. For instance, community health workers could engage with community members to increase access to and uptake of prenatal care or serve as community messengers for the Universal Home Visiting Program. Although complementary, these services shall be administered independently. The Family Connects model integrity standards require universal nurse home visiting to operate independently of other services. Each category must have separate and unique administrative and supervisory structures if both are housed in one organization. At the same time, it is critical that the Community Health Worker Program and the Universal Nurse Home Visiting Program are collaborative and work together to achieve positive family and community outcomes and create an effective continuum of care for all prenatal and perinatal families in the Greater Bridgeport region. Families will be connected to a community health worker through multiple settings, including hospitals, community-based organizations, and community health centers. Community health workers will create a continuum of care and help families navigate health services before, during, and after pregnancy. Community health workers will provide coordination with state agencies, community-based organizations, community health centers, and hospital systems. Community health workers will connect pregnant and postpartum mothers, fathers, and families to necessary services and provide certain screenings. In addition, community health workers will act as the liaison between the family and their healthcare provider, support and educate families on the use of healthcare coverage, and connect families to social and other services that may be needed. Lastly, community voice and need would drive the design of the community health worker integration. Community health worker training under the Notice of Funding Opportunity will include community health worker core curriculum training from an organization approved by the Community Health Worker Advisory Board. A listing of approved training organizations can be found on the link on this slide. Additional trainings shall include, but not be limited to, lactation, substance use, depression, anxiety, stress, intimate partner violence through the Connecticut Coalition Against Domestic Violence, which will be offered free of charge. The applicant may choose another training program for intimate partner violence. The funding opportunity includes the fee for certification for community health workers. The certification requirements are through the Connecticut Department of Public Health, and the information can be found again on the link on this slide. You may utilize the funding to pay for tuition, upskilling, certification, salary, and fringe for community health workers. Integration and enhancement of existing service delivery by community health workers includes, but again is not limited to, prenatal and early postpartum visits, provide resources for people experience intimate partner violence, assess for food insecurity, substance use, chronic conditions, maternal child health and early childhood needs, lactation assistance, general health, and any other intervention as needed. The community health worker will help connect families to identified service needs and healthcare providers as needed. And now I will turn it over to Kathy Lenahan, the Grant and Contracts Division Director, who will walk you through the evaluation and scoring for the RFP.
Good morning, everyone, again. As Ashley just said, I will be walking through some of the highlights or the key areas for both our evaluation and a proposal submission section. So Debbie, if you want to go to the next slide, that would be great. So it is the intent of the agency to conduct a comprehensive, fair, and impartial evaluation of the proposals received in response to this RFP. In order to do this, the agency will designate a review committee to evaluate proposals submitted in response to this RFP. The review committee will be composed of individuals, agency staff, and/or other designees as deemed appropriate. The contents of all submitted proposals, including any confidential information, will be shared with the review committee. Only proposals found to be responsive that is complying with all instructions and requirements described within the RFP will be reviewed, rated, and scores. Proposals that fail to comply with any instructions may be rejected without further consideration. And so what you see in front of you is the evaluation and scoring grid and the weights that are associated with each of the criteria for this RFP. I want to have you look at, when you're reviewing your application, we have provided the evaluation criteria, excuse me, on page 28 of the RFP, where it goes into more detail as to what would a top score look like. So it gives you criteria A, which is organization and strengths. It gives you your percentage total, and then it goes through what a high quality response will look like for each of the categories and criteria. So criteria B, partnerships. Again, it describes what a high quality response will look like. And in this section, we also break it down to what a high quality response will look like for both the universal nurse home visiting applicants and the community health worker applicants. And so as you see, it goes through all the different criteria. Next slide, Debbie. So as we as I started with, it's important that your application comes in with all of the elements that are required. We have provided a proposal content checklist, which can be found on page 50 of the RFP. And what we're looking for is to make sure that you have a cover sheet. Again, right here, we reference that it is page 26 of the RFP, that you provide a table of contents, that you have an executive summary, which would be a high-level summary, not exceeding 2 pages of the main proposal and cost proposal. The summary must include the organization's eligibility and qualifications to respond to this RFP. And finally, the summary will clearly state whether you as the applicant is applying for home visiting component, the community health worker component, or both, and whether you will be subcontracting out any of your work. We talk about the main proposal body. Again, I think we referenced this earlier. There's a 35-page limit if you're applying for category 1 for one category, or 45-page limit for 2 categories. We have the required attachments on the proposal content checklist. We need program organizational charts detailing reporting structure. We need the resumes of your key staff, 2 letters of commitment, organizational data security procedures if not described in your main proposal. If applying for a single category, you would need a letter of commitment from partner applicant from other agencies. And if the applicant chooses to subcontract any components, a letter of commitment from the subcontractor. Then we talk about optional attachments, and they can be found also as appendices. And then some of the other forms, the IRS determination form, if it's applicable for your organization, 2 years worth of relevant financial audits and financial statements, the conflict of disclosure statement that you must provide, and there's guidance provided on that. Statement of assurances, which can be found on page 48 of the RFP. And then the proposed budget, which would include a narrative and a cost schedule for planned subcontractors, if applicable. We want to note that the budget that is required for this application can be found in a separate document, both through CT Source and on the OEC website for the RFP section. The budget has 2 tabs. So you see a screenshot here of one of the tabs, and there is another tab that is associated with this budget. Both tabs must be completed and submitted with your application. Thank you.
Thank you, Kathy.
Welcome.
To summarize the RFP submission process, proposals must be submitted electronically by 5 p.m. on August 3rd. The subject line of your email must include the RFP name. As a reminder, the maximum size of files per email is 25 MBs, and all documents requiring signatures can be downloaded and signed and then uploaded and scanned as part of the final submission package, and electronic signatures are accepted. Please don't forget to register with the state contracting portal and to do a final formatting check. Contact information for this RFP is listed on this slide. And as a reminder, questions and answers, responses will be posted every other Friday from July 1st until the RFP closes. Key dates for the RFP submission. To review, today is the mandatory bidders conference. July 13th by 5 p.m. is a mandatory letter of intent. August 3rd, the RFP is due by 5 p.m. To reiterate, questions must be submitted in writing by Thursdays at 5 p.m. from June 30th to July 28th. Questions Answers to questions will be posted every other Friday from July 1st to July 29th, and written responses can be found on the website. Thank you, and we look forward to working with you.